بسم الله الرحمن الرحيم. I'm Professor Dr. Magda Nazir. I'll go through the parasitic diseases concerning blood and lymphatic system. In this block, I'll give you two lectures which are concerning these parasites. The first lecture will begin with hemoflagellates. We must know the types of human parasitic species. We'll know also to identify the species, their localities and vectors, the basic knowledge of clinical disease and how it occurs. Also, we must have good knowledge about the diagnosis, treatment, and prevention of each disease. Hemoflagellates are characterized by having kinetoplast and flagella for motility. They are transmitted by insect vectors, and their types are: first is the A mastigote, which has a nucleus and kinetoplast and is oval in structure. The next is promastigote, which has an anterior kinetoplast and flagellum. We'll know how it works, how it moves. It moves directly towards the direction of the flagellum. So the area where is the kinetoplast and flagellum coming out is the anterior part of the spindle-shaped promastigotes. Next is the epimastigote. The epimastigote, the kinetoplast is directed further backwards and is present around the nucleus. So when the flagellum comes out, it moves up while inside the cytoplasm of the cell and then comes out from the anterior end. When it is moving in a wavy mode. So we must see that the flagellum is waving inside the cytoplasm and then coming out. This wavy part is, we call it undulating membrane. Then the trypomastigote. The trypomastigote has the kinetoplast in the posterior end. So the flagellum moves towards the anterior end, making a long undulating membrane alongside the whole cell of the trypomastigote. The first lecture we have Leishmaniasis, and then the other hemoflagellates. We'll discuss them in the second lecture. Leishmaniasis has two main types, cutaneous and visceral leishmaniasis. We are concerned with visceral leishmaniasis in this lecture, which is usually caused by Leishmania donovani and Leishmania infantum in our region, which affects young and elder children only, but not present in adult stage. It is characterized by progressive fever, weight loss, splenomegaly, hepatomegaly, hypergammaglobulinemia, and pancytopenia. Kala-azar is lethal nearly to all untreated cases, and is in treated patients, case fatality rates are often more than 10%. This, or around 10%. This shows how this disease is serious. Life cycle and morphology of Leishmania donovani or visceral leishmaniasis. The life cycle and morphology are essentially the same as those causing old world cutaneous leishmaniasis. However, A mastigotes can be found throughout the body and are not confined to the macrophages of the skin. They are present in the macrophages of the blood, which are the monocytes and are carried to the reticuloendothelial centers such as bone marrow, spleen, and liver. So we call it visceral leishmaniasis. The life cycle begins with the vector, the phlebotomist, taking a blood meal with the A mastigotes inside a monocyte. Then the A mastigotes transform into promastigotes. The promastigotes replicate inside the gut of the phlebotomist. Then they pass to the foregut. When the phlebotomist bites another person, they are injected with the saliva inside the body. Then they, the promastigotes transform into amastigotes, which are engulfed by the monocytes and tissue histiocytes. Then they pass to the circulation and settle in the parenchymatous organ, which have reticuloendothelial cells. This is, in brief, the life cycle, and it is the replication of the amastigotes inside the reticuloendothelial cells is the main cause of the pathology or the symptoms which we discuss later. These are a diagram of a macrophage having the amastigotes inside, and other amastigotes are free outside seeking other macrophages to replicate inside them. This is a stained smear showing the amastigotes inside the macrophage. This is another stained smear from the spleen showing also the amastigotes inside a macrophage and outside free in the smear. We come to the clinical disease. The incubation period usually ranges from 2 to 6 months. The onset in naive, non-immune patients may be acute with high fever, chills, anorexia, malaise, weight loss, and diarrhea. This occurs due to the spread of the amastigotes inside the whole viscera of the body, having reticuloendothelial cells, as we said before. The fever is double peak, meaning it is in the morning and evening, and the patient is often weak and appears emaciated due to the prolonged fever. Common clinical signs include a non-tender enlarged liver, a markedly enlarged spleen, femoral and inguinal lymphadenopathy. Also, the skin changes which are characteristic of the disease are dark discoloration of face, hands, feet, and abdomen, particularly in India, where the patients acquire an earth gray color. This darkening of the skin gave the name Kala Azar or the black sickness. After cure of the initial disease, there may be a post-Kala Azar thermal leishmaniasis, which is usually developing in some zones or two distinct zones, which are namely South Asia and East Africa. South Asia and East Africa people may have macules or papules beginning first around the mouth and then spread to the face and then to the extensor surfaces of arms and the trunk and the legs. These enlarge, fuse, and may resemble leprosy, making large papules which distort the face and also appear in the trunk. If we have biopsy from these nodules or these papules, we'll find some few mastigotes inside. In this case, we can consider these patients as reservoirs for the infection. This is a picture of a patient with Kala-Azar, a young girl having hepatosplenomegaly, and also she has the forehead darker in color than the face, and also the hands, as you see, are darker than the face also. We can see also a blood film from this patient showing a macrophage with the mastigotes inside. This is a case of post-Kala-Azar dermal leishmaniasis, and there are the papules all the face around, and also they are here coalescing to make larger papules which distort the face here and show the faces nearly that of a case of leprosy. Diagnosis: patients generally have anemia, which is normocytic normochromic anemia, leukopenia, thrombocytopenia, and hypergammaglobulinemia. This is by the ordinary investigations we can do for everyone. There is definite diagnosis to demonstrate the mastigotes in tissues and or clinical specimens or the promastigotes in culture. The splenic puncture, if we have to demonstrate the parasite, we won't do this because splenic culture, which has a high rate of organism detection, there is a high degree of risk for the patient, because if spleen ruptures for this huge size, it may cause very severe bleeding. So the safer process, we must have lymph node aspirate or liver biopsy or bone marrow aspirate, because this is very important to differentiate between the infectious mononucleosis or the lymphomas and the disease. Culture and animal inoculation studies are also helpful. The culture is done on NNN media as in case of cutaneous leishmaniasis. Also, the animal inoculation can show the disease after a while when we have a blood sample to be inoculated in laboratory animals, especially hamsters. We can do also formol gel test, which is a test using the serum of the patient, and also we add to the serum of the patient commercial formalin, so we call it formol gel test because the serum of the patient jellifies after a while due to the high content of protein or hypergammaglobulinemia. It is a helpful negative test because if it is negative, we don't have hypergammaglobulinemia, so maybe we don't have Kala-Azar. But if it is positive, it is a clue for the disease. Also, we can do skin test like tuberculin test in the main concept. The skin test is made by the extract of the parasite to be injected intradermally after 48 hours if we see a skin reaction, it is positive. Detection of the parasite genetic material or antigen detection by PCR and by immune tests like ELISA, indirect heme agglutination, indirect fluorescent antibody tests are useful and sufficient for confirmation of the disease. This is a picture showing an example of the rapid tests which can be done as a field survey for detection of Kala-Azar. It is important in the endemic areas. Treatment. The patients should receive supportive care because they are very weak and emaciated. Also, we give pentavalent antimony compounds which have been the drug of choice. Also, recent treatment is lipid-associated amphotericin B. Concerning epidemiology and prevention, it depends on a number of factors, including the interaction between sandflies, reservoir hosts, and susceptible humans. These are the main cycle of the disease because if we treat humans, some reservoir hosts in the community may cause the cycle to be continuing and reinfecting humans again. The disease is a zoonosis, which means that it is present in animals and man can get the infection also. Except India, where the humans serve as the major reservoir host and at the same time they are the patients. Dogs and other canines are good reservoir hosts for Mediterranean Leishmania infantum and also in the African type of Kala-Azar. Use of residual insecticides is the main preventive measure to get rid of sandflies because they are very small, they are weak flyers, so they are around the houses, around the animal sheds, and everywhere where are small animals, so they can be eradicated by using residual insecticides around the places where they breed at. Now we go to the next part of the lecture. We see first what we can get from them. Concerning Toxoplasma gondii, we must have a good knowledge about the parasite. Also, we can know the mode of infection, the pathological effects, and its clinical disease, its diagnosis and treatment. Also, we must have a fair knowledge about lymphatic filariasis, which type is present in Egypt, how can we diagnose it and manage the case. The student should know also about an African parasite or African filarial worm called lua lua, which is an African eyeworm. The microfilariae of this worm can be present in peripheral circulation. So we must differentiate them from those for lymphatic filariasis. Toxoplasmosis is the disease caused by Toxoplasma gondii, which is worldwide in distribution. It infects many vertebrates as well as humans. All of us, we and the vertebrates are intermediate hosts for Toxoplasma, but the definitive host is the house cat or other members of the Felidae family, means the wild cats like lions. As an example, they are the definitive hosts for Toxoplasma. There are three infectious stages for Toxoplasma gondii. The tachyzoids, tachy means rapid, so the tachyzoids are actively, rapidly dividing sporozoites of Toxoplasma in groups or clones inside the macrophages of the body. The other is the bradyzoids, which is present in tissue cysts. Brady means slowly dividing non-active sporozoites, which are hiding inside the tissue like brain and muscles from the immune reaction of the host. Also, there are the sporozoites inside the oocysts or the sporocysts coming out from the cat in the cat feces as a result of the sporogony cycle inside its intestine. The organisms are obligate intracellular parasites and are found in two forms in humans: the actively proliferating trophozoites or sporozoites or tachyzoites, which are usually seen in the early and more acute phase of infection when immunity is low for them. They invade any tissue in the body, but they can infect people through blood transfusion and also through congenital infection. The second form is the resting form or tissue cysts, which are found primarily in muscles and brain, even in uterine muscles to be, as we see, they are hiding from the immune reaction of the body when the patient builds immunity against Toxoplasma. This is a diagram for the tachyzoids inside a macrophage and also the tissue cyst forming inside the brain or muscles as we see. This is a stained film showing the tachyzoids and one of them inside the macrophage. The other is a tissue cyst in the brain tissue. We see the brain tissue around and like hyaline tissue, and this is the tissue cyst stuffed with the bradyzoids as we see. Life cycle. The life cycle of Toxoplasma is naturally going on between cat and mice, but the cat can give us, and also the other animals, the shed oocysts in stool. These pass into the ground and can infect mice, can infect the can infect mice, can infect other birds which are present around, like domestic birds, which are usually picking something from the ground. Also, they can infect the sheep, the cattle, any grazing animals can also have infection through the oocysts of the cat. Man can be infected also through ingestion of undercooked, the cat oocyst also can get infection from ingestion of undercooked meat, having tissue cysts from any animal we can eat, also from the vertical transmission through from mother to fetus through the placental barrier. This is by the tachyzoids. Also, organ transplantation. This can be by the tissue cysts, gardening without gloves, also cat oocyst exposure, and whole blood transfusion. All these can infect man with toxoplasmosis. Then we see the clinical presentation of the disease. The first and the most common is congenital toxoplasmosis. This results from acute primary infection of the mother during early pregnancy. This causes many serious manifestations in the outcoming fetus. Acquired toxoplasmosis, which is our concern here, is usually asymptomatic or mononucleosis-like syndrome in immune-competent patients or the patients with good immunity. They either have the disease subclinical, asymptomatic, or they will have some fever, lymphadenopathy, and rash, and this is like infectious mononucleosis. Also, infection may remain latent for life, and the patient's serum is positive for toxoplasmosis, but he doesn't have any symptoms appearing on him. Um, Unless there is reactivation due to immune suppression for any cause, then we have the manifestations like mononucleosis like syndrome. The tissue cysts are found in the brain and muscles of any intermediate host having chronic toxoplasmosis. In immunocompromised patients, who are now very commonly met with due to any cause of immune suppression, like we have some tumor treatment, or due to any weakness occurring for the patient. In immunocompromised, most commonly in AIDS with CD4 less than 200. The encephalitis is the main manifestation with focal central nervous system lesion seen as single or multiple ring enhancing masses on computed tomography or CT, and focal neurological signs according to the region affected in the brain. Also, there is lymph node, liver and spleen enlargement, and pneumonitis. Also, there may be choroidoretinitis or affection of the retina with toxoplasmosis as a part of the optic nerve. Investigations or diagnosis of the disease, we have serology, which is the main investigation for diagnosis. Serology detecting the positive immunoglobulin M for toxoplasma is important to detect active disease. If we find immunoglobulin J only positive, this is a chronic disease and the patient is asymptomatic. In some survey, we found that 50% of pregnant women are positive for IgG, and their outcoming children came healthy and very good. This can be discussed later in OB/GYN block. Now we can find also the sporozoites in CSF stained with GIMSA. Also, antigen or DNA detection by PCR is helpful for detection of the disease. And also, pathology provides definitive diagnosis when we have biopsy from lymph nodes or from the liver to find the tachyzoids in acute disease, also in the immunocompromised persons. In immunocompromised patients, we consider CT scan for their neurological manifestations because if they aren't apparent, they will appear later. The CT scan shows ring-enhancing lesions or cortex or deep nuclei in the cortex or deep nuclei as they can tell in the CT. Also, ophthalmologic examination for choroidoretinitis must be done. Negative serology in many AIDS patients is false negative due to decreased immunity, so we don't have building immunoglobulin G. Treatment and prevention. No treatment if the patient is immunocompetent, not pregnant, no severe organ damage. Also, in HIV patients or in AIDS patients, we give pyrimethamine and sulfadiazine. In eye disease and meningitis, we give plus the previous drugs, corticosteroids to lessen tissue reaction. Proper hand hygiene, cooking meat thoroughly to proper temperature is the main preventive measures for toxoplasma. Now we come to filarial nematodes. Filarial nematodes are a group of arthropod-borne worms that reside in the subcutaneous tissue, deep connective tissue, lymphatic system, or body cavities of humans. They are called filarial nematodes because they are very thin and long. The female worms produce large numbers of microfilariae. The microfilaria are considered the eggs of these nematodes or pre-larval stages, which are highly motile, thread-like, and they are, in some species, maintain the egg membrane as a sheath. These are called sheathed microfilariae, and there are unsheathed microfilariae also. Microfilariae can be detected in the peripheral blood or in the cutaneous tissue, depending on the species. They are not infective for other vertebrate hosts, even if we have blood transfusion and there are microfilariae inside. Also, they don't undergo any further development inside the human body. They develop only in the insect vector. The infections are transmitted to humans by the bites of the obligate blood-sucking arthropods that become infected through ingestion of microfilariae in a blood meal and obtained from a mammalian host. In the insect, the microfilariae develop into infective larvae which stay in the insect mouthparts for next infection. Depending on the species, microfilariae may exhibit periodicity in the circulation of the human host. When the largest number of microfilariae occur in blood at night, it is called nocturnal periodicity. If are present in the daytime, we call it diurnal periodicity. Some non-periodic microfilariae occur equally by day and night. Subperiodic means that they are present more at night but can be present during day. When not in the peripheral blood, microfilariae are found primarily in the capillaries and blood vessels of the lung. The basis for filarial periodicity is not known till now, but it may be adaptation to the biting habit of the relevant vector. We'll see this during discussion of lymphatic filariasis. Lymphatic filariasis is caused mainly by Wuchereria bancrofti. An estimated 300 million people, primarily in India, Southeast Asia, Sub-Saharan Africa, live in areas where lymphatic filariasis is endemic, and at least 130 million people are probably currently infected. This infection is present in Egypt, and ancient Egyptians and Hindu and Persian physicians were the first to note elephantiasis, which is the end outcome of the disease. Humans and mosquitoes of the genus Culex are necessary to complete the life cycle of Wuchereria bancrofti. Culex mosquito is the mosquito present anywhere, but some of its species or subspecies are only the one who transmit Wuchereria bancrofti. So we can find it in some foci around us. Near us there is a focus in Khela and in Sitfa. Clinical disease. The early symptoms of filariasis include high fever, filarial or elephantoid fever, lymphangitis, and lymphadenitis. Filarial fever usually begins with a high fever and chills that last for 1 to 5 days before spontaneously subsiding. The lymphangitis extends in a distal direction from the infected nodes, meaning that they radiate down through the legs. Lymphangitis and lymphadenitis develop in the lower extremities more than in the upper extremities. There can be genital scrotal involvement, almost exclusively feature of Wuchereria bancrofti infection. The lymph nodes affected are epitrochlear, femoral, and the nodes are firm, discrete, and enlarged and tender. Later on, the lymph nodes and lymphatics are obliterated, so the overlying skin will be tense, erythematous, and hot at the first, and the surrounding area is edematous. Repeated inflammatory attacks lead to fibrosis and obstruction of lymphatics, as we say. Distally, lymphedema occurs with hard browny edema, which can be non-pitting, and thickening and verrucous changes occur in the skin, also known as elephantiasis. This is the picture of a microfilaria of Wuchereria bancrofti. Characteristically, when we see a closer view, that there is a sheath around extending behind the posterior end of the worm. Also, this is the sheath, and also here there are no nuclei in the posterior end. This is a case of elephantiasis. See or compare how it is affecting one leg and the other is clear. Tropical eosinophilia. This is a characterized by pulmonary infiltrates, peripheral eosinophilia. During investigations, the patient has cough asthmatic attacks, especially at night. and a history of prolonged residence in the tropics. These patients have high immunoglobulin E level, high antifilarial antibody titers, and also they have no microfilari in the peripheral blood. But if the patient is given diethylcarbamazine, which is the treatment of filariasis, he improves dramatically. When we come to diagnosis is mainly by detection of microfilari, but after this we must have to know that usually now they have the immune reactions and the immune tests better for diagnosis than detection of the microfilari because it is tedious. Microfilari of Wuchereria bancrofti don't appear in peripheral blood except between 10 p.m. and 4 a.m. Before this, we may find from 8 p.m. We may find some microfilari, but it is better to be taken after 10 o'clock in the evening. Microfilari may also be found in hydrocele fluid and urine in advanced cases with hydrocele and with chyluria. Not technique is having 1 milli of blood with 10 milli formalin to 2% and then centrifuge to examining the sediment. Also, there are nucleopore filters to trap microfilari after the red blood cells have been lysed by HCl dilute. Provocation test is done to detect microfilari at daytime by giving a single dose of the treatment diethylcarbamazine. Blood should be drawn within 15 minutes to 1 hour for detection of microfilari. Serology for detection of antibodies or circulating antigen is usually done to confirm diagnosis. Also, PCR is useful to detect the species of filariasis. Ultrasound is used to confirm as well as to predict the clinical outcome of lymphatics of the infected patients. Treatment. The two important drugs for treatment of filariasis are diethylcarbamazine, DEC, and ivermectin. Ivermectin may be given in combination with albendazole in those who have resistance to diethylcarbamazine or have some allergic manifestations. Prevention is mainly by vector control, then mass treatment of people in endemic areas. Now we have another lymphatic filariasis causative worm is Brugia malayi. Brugia malayi, from its name, it is present in the Far East or in Southeast Asia, but we have those people around us because Chinese come here and there and we meet them now, and some of them became natives in Egypt. So we must have a little impression or little idea about this worm. It is having the life cycle similar to that of Wuchereria bancrofti. The morphology is different somewhat. We must see that the microfilaria has two single nuclei in its posterior end, but the outcome of Brugia malayi for saying about elephantiasis is different also from that of Wuchereria bancrofti. Wuchereria bancrofti has elephantiasis extending above the knee and there is scrotal swelling. This never happens for Brugia malayi, which affects only the lower extremities below the knee. Concerning Lua Lua or the African eyeworm, the adult worm migrates in the subcutaneous tissue, not in lymphatics like those before, and it causes some we call calabar swelling, which is intermittent in the skin where the worm was, not the worm is, because it is an allergic reaction occurring after the worm leaves the place. In addition to the migration beneath it can also migrate beneath the conjunctiva, and the microfilariae of it are present in blood. The vectors are biting flies called chrysops and are known as deer fly or mango fly in Africa. The microfilaria has has a diurnal periodicity whose peak occurs around midday and are sheathed. The body nuclei are continuous to the tip of the tail. Here we see that the nuclei appear around in the tip of the tail. The clinical disease of Lua Lua is erythema, swelling, itching in the places where the worm is. After the worm migrates, we can see the swelling enlarging and prominent. Adult migration is not painful and seldom noticed unless the worm is passing over the nose bridge or through the conjunctiva of the eye. These are the main parts where we can see the worm. The most common manifestation is calabar or fugitive swelling predominates on the extremities of the immigrant people, not the native people. Serious complications include cardiomyopathy, encephalopathy, nephropathy, or pleural effusion. They occur with high microfilaremia or during treatment. This is a picture of the worm inside the eye. Now we can get it out when it is in the conjunctiva. Also, this is a picture of calabar swelling on the hand of the patient. Diagnosis is the same with Fisheria bancrofti for detection of microfilaria in blood. Adding to this, the clinical signs of the worm crossing the conjunctiva. Treatment is the same also as Fisheria bancrofti, but gradual dose and corticosteroids are recommended with high microfilaremia. Surgical removal of the adult worm as they are migrating across the nasal bridge or through conjunctiva is good treatment because it gets us rid of the worm. Control of loiasis depends on a great degree on the chemoprophylaxis with diethyl carbamazine for the native people and those who are coming in endemic. These are some questions for your self-assessment. You can revise them, and if you don't know anything, you can go back to the lecture. Good luck, and we'll see you in the next lecture, inshallah.